So I think we'll begin our St. Michael's Hospital Division of Cardiology rounds. We have a special guest from far away, from downtown Toronto anyways. So it'll be my pleasure to introduce to everyone Dr. David McCarty, who's a senior lecturer in medicine at Kamuzu University of Health Sciences and a consultant cardiologist at the Queen Elizabeth Central Hospital in Malawi, Africa. And David, who I believe has spent some time at the University of London, Western Ontario, in London, Ontario, a little closer to our home here, is now a key member of, I'm not sure if it's pronounced MTIMA. You'll tell us a little bit more about that. And also our own, very own Carlos Fernando is also a key member of an organization that is going to talk about cardiovascular disease in Africa, an increasing but treatable global health concern. So David, I'll advance the slides to give you the bandwidth for at least the audio. Really appreciate you taking time to visit with us virtually.
Thank you very much, Sean, and welcome everybody. I do appreciate the invitation because of the technical challenges that we had back in September. So this is the subject that we're going to talk about, and we could move to the next slide, please. As Sean has mentioned, I am affiliated with a number of organizations, and these are my disclosures. I don't get any reimbursement from any of these organizations, but I'll be talking about them this evening or this afternoon over there in Toronto. And then moving on to the learning objectives. I give the talk the very grand title of Cardiovascular Disease in Africa, but really we'll be confining it to Malawi, the small country in which I currently live. And we're going to talk about a few things: chronic rheumatic heart disease, heart failure, and then perhaps some discussion at the end about possible collaboration. So next slide. Here, of course, is Africa, and down to the southeastern tip, not labeled on this map, but on the next one beside Mozambique, Zambia, and Tanzania is the small country of Malawi, famous for its lake, which occupies about a quarter of the land surface of the country. It's below the equator, and if we just zoom in further on the next slide, you'll see a bit more of the local geography. So there are about 4 main cities in this country, which is about 800 kilometers by about 250 kilometers at its widest point. If we move on, the population, as you see, is estimated now somewhere in the region of 21 million. And the per capita GDP is only $1,700 according to the International Monetary Fund. That's an overestimate for most of the population, with about 2/3 living below the poverty line of about $1.90 cents per day. And on the next slide, you can see that the population's about half the country's under the age of 20. They speak a number of languages, of which the main one is a Bantu dialect called Chichewa. It's quite a colorful language. The currency is called the kwacha, and about 85% of the population of this small country are subsistence farmers. Access to electricity is limited to about 20%, as is access to employment, formal employment opportunities, healthcare, education, and transportation. There's quite a burden of communicable diseases, and the HIV prevalence is the lowest it's been in the last 20 years or so. On the next slide, I've just included some photographs of rural Malawi. Many people live still in mud huts, which are grass thatched. They draw water from rivers or boreholes, as you see here, often by ladies who carry it on their heads. And many of the roads in the country are mud, which is a real challenge when it comes to the rainy season, which is the current season in the country. We'll move to the next slide. So the Malawian healthcare system is a national system. It's paid for by the government, but is very limited in extent. Primary care is delivered by medical assistants. These are not trained to the level of nurses, but they have rudimentary medical training at health centres across the country. Mainly they are dealing with malaria, infectious diseases such as pneumonia and hypertension. For those who have more complex conditions, they're referred to their district hospitals at which secondary level care is provided. And this is by a cadre called clinical officers. The most similar job description for North America would really be physician assistants or nurse clinical specialists. Tertiary referral is to one of 4 central hospitals located in the cities that were illustrated on the map at the beginning. One is in the former capital city of Zomba, one in the current capital, Lilongwe, one in Blantyre, where I live, and one in the north of the country in Mzuzu. Clinical officers follow protocolized care produced by the Malawi Ministry of Health, and it's kind of standard to be treated for hypertension, epilepsy, diabetes. Everything follows those guidelines, which are usually many years out of date. As we say, services are free, but they are extremely limited, and patients often have to pay for medications and laboratory tests, which are unavailable even at the big central hospitals. If we go to the next slide, this is Queen Elizabeth Central Hospital at which I work. It looks very nice from the front. If we move to the next slide, it shows one of the medical wards, which is very overcrowded. As you can see, patients are almost one on top of each other. We haven't really got to the stage of patients being underneath the bed, but often the corridor in the middle is full of patients who lie on mattresses. And the next slide. So it would be regarded as the premier public hospital in the country. It's a tertiary referral centre, and the other tertiary centres would also refer to it. It's where the medical school is based. It predates Malawian independence. Malawi was a colony of the UK and received independence in 1964. And although it's called the Queen Elizabeth Central Hospital, it's actually named after Queen Elizabeth, the Queen Mother, not Queen Elizabeth II, the recent Queen. It's very large with several hundred beds, a large number of obstetric and pediatric patients, and there are some specialist units, though no cardiology unit. If we can move to the next slide. My current employer is the only medical school in the country. It's termed the Kamuzu University of Health Sciences. It previously was part of the University of Malawi, but the government delinked the constituent colleges of that university several years ago to form 5 new universities, one of which is the Kamuzu University of Health Sciences. The campuses are based in Blantyre and in the capital city, Lilongwe. In this country of 20 million population, it takes about 100 students in per year, and the Department of Medicine has 13 faculty, of whom several are currently out of the country for subspecialty training. Of course, as Dr. Goodman alluded to, I moved from London, Ontario, where we had, I think, 35 in our division of cardiology. So it's a big change. Malawi is very proud of its medical school, and they've put it on the back of the 100 kwacha banknote. At the time of independence, 1 kwacha was equal to $1 US. Now it would cost about 1,950 kwacha to purchase that US dollar. And in fact, one of the currencies which is more expensive than the US dollar in Malawi is the Canadian dollar, which it would cost about 2,050 kwachas to purchase. The next slide. As Dr. Goodman mentioned, I've had a varied career. I trained in the United Kingdom and then moved to Boston for a subspecialty echo fellowship before accepting a faculty position at the University of Western Ontario. I was in London for about 11 years. During that time, I majored, I guess, in echocardiography. I was the head of the echo lab for 6 or 7 years of that time. But I started traveling to Malawi in 2013, really for the purposes of teaching some of those medical students. Although there's 80 to 100 in each year, they are divided into 4 groups and so rotate through final year medicine department in groups of 15 or 20. The next slide. The university's well affiliated with a number of North American universities and also universities in Western Europe and the United Kingdom. And we get quite a number of visiting lecturers. There's a strong link with infectious disease units across Europe and also with radiology. They have a radiology training program. This is one of the radiologists who spoke to us a couple of years ago. And then the next slide. While I was based in London and coming intermittently to Malawi, I had the pleasure and privilege of taking many Canadians with me, ranging from cardiac sonographers through cardiologists. Dr. Ashley Heidema is just recently stepped aside from being the program director in London. She came as a resident several years ago. Some nurses, perfusionists, but mainly sonographers and trainee cardiologists. So then moving on to some of the things we want to talk about. The next slide, non-communicable disease in Malawi. Of course, most of sub-Saharan Africa has traditionally had a very high communicable disease burden, not just the tropical diseases like malaria, but also tuberculosis and, of course, HIV with all of the opportunistic infections associated with that. However, about a third of deaths are now due to non-communicable diseases, of which cardiovascular are the biggest contributor. And the exact prevalence of many of these conditions in Malawi is not known. The next slide. When I started to come to Malawi, research was governed by a national agenda, and it's hard to read, but on the right side of the slide, it gives the themes for research mandated by the Ministry of Health for non-communicable diseases. The first one of these was cardiovascular disease, and the top priority was determining the burden and trends of cardiovascular disease in Malawi. Nothing molecular, nothing high tech, just how much of the disease there is. If you go to the next slide, you can see how a few years later, they published a midterm review on that health research agenda, and cardiovascular research was dismal. I'm not a researcher, I'm more of an educator, but you can see the very poor number of papers that have been published in the domain of cardiovascular health during the period of that review. One of the papers was from the previous head of the Department of Medicine, a lady called Teresa Lane, on the next slide, who published the spectrum of heart disease in patients presenting to the Department of Medicine in Queens. And she really did emphasize that it was very important to characterize the disease. Epidemiologists think a lot about hypertension as being a cardiovascular disease, and of course it's an important cardiovascular risk factor, and hypertensive heart disease and the complications of hypertension are cardiovascular conditions in their own right. But to truly understand the prevalence of cardiac diseases, we need to use more of the tools, and in particular echocardiography. So if we move to the next slide, we'll talk a little bit about rheumatic heart disease. So as you see here, we've got the classic form of rheumatic heart disease. This is a parasternal long axis view showing doming of the mitral valve in diastole, classical of mitral stenosis. We can move through the slides, I think, reasonably quickly, Sean. This slide's just demonstrating that there's no significant mitral regurgitation complicating the mitral stenosis. And on the next slide, we see a short axis view at the level of the mitral leaflet tips, allowing us, if we then move to the next slide, to calculate the mitral valve area by planimetry, which in this case is 0.6 centimeters squared, very severe mitral stenosis. The next slide shows an apical four-chamber view with the color again demonstrating no regurgitation. If we look at the gradient across this valve and the pressure half-time on the next slide, you can see the pressure half-time again corresponds to mitral valve area, which is severely stenosed. And then, as you see, the mean gradient at a heart rate of 74 beats per minute is about 17 millimeters of mercury. This is in a 36-year-old lady who presented with increasing shortness of breath. Mitral stenosis, the classical rheumatic disease beloved by medical students and examiners. If we move to the next slide, we can ask, how would we treat a lady like this in Canada? Well, of course, we have many options. First, we'd want to control her ventricular rate, put her on anticoagulation. And then think about definitive treatment for someone with this stage of the disease, perhaps balloon mitral valvotomy or open mitral valve surgery. In contrast, in Malawi, if we go to the next slide, rate control with beta blockers is available. Occasionally, calcium channel blockers and digoxin are also found. However, anticoagulation is a major challenge. We know from the Invictus study conducted from Hamilton, and in which our hospital participated, that NOACs are contraindicated for rheumatic atrial fibrillation. We don't often find warfarin in the public system in Malawi, and INRs are not generally provided. It's something that patients have to purchase. For definitive management, cardiac surgery is not available in the country, and so patients are added to a long government waiting list to go abroad for interventions, whether that's balloon valvotomy or mitral valve replacement. The young are prioritized, often pediatric patients with congenital heart disease, and so many adult patients succumb to their illness before they have the opportunity to move. In the case of this lady, she was referred to a visiting team of interventional cardiologists and cardiac surgeons that I'll speak about later. So that's classical mitral stenosis. However, it's not the most common form that we see, even in Canada. In First Nation populations, the next form is more common. If we go to the next slide, we can appreciate the fixed tethered posterior mitral leaflet that is just pulled away from the anterior leaflet, leaving it no room to coapt with. And unlike the 36-year-old who I just showed you, these images are from a 17-year-old. You can see the really torrential mitral regurgitation. And we see many of these patients who have had repeated episodes of rheumatic fever subclinically, presenting in late teenage years or early adulthood with severe mitral regurgitation and heart failure. It's the commonest form of the condition that we see. If we move to the next slide, you can appreciate the very substantial left atrial dilation, reflecting the predisposition to atrial fibrillation in these patients, and the hyperdynamic ventricle, which of course is falsely reassures us. If we move to the next slide, in the presence of that severe mitral regurgitation. So this is a much more common form of rheumatic disease that we encounter here. And then finally, I'll maybe just show a couple more slides, a few more slides of a different form of patient we saw recently. This is a 23-year-old man who presented with angina at rest with a blood pressure of 130/30. And you can see his ventricles very dilated. It measured about 8.5 centimeters. And if we go to the next slide, I hope you can appreciate that the aortic valve is very rheumatically deformed. And the next slide shows the very severe aortic regurgitation. He had all of the classical signs of severe aortic regurg and was having rest angina because of his very low diastolic pressure. The next slide shows that his ventricular function is starting to drop. And then together with rheumatic disease, we'll just look at one more case and then move on. We also see a lot of uncorrected congenital heart disease. This is a 20-year-old lady who was referred from the far north of Malawi. You can maybe appreciate the right axis deviation on the ECG and the right ventricular hypertrophy. And then she's got prominent pulmonary arteries on her chest X-ray with perhaps some pulmonary pruning. On the echocardiogram, if we proceed, you can see a dilated right ventricle. Moving then on to the next image, some flattening of the interventricular septum during systole. And the next slide again shows a dilated right ventricle on the four-chamber view. And the reason we can start to appreciate is a secundum ASD down in the interatrial septum. There we're zooming in, and the next slide shows color with predominantly left to right flow. So we do see uncorrected congenital heart disease as well. The next slide. So this is a young lady with a secundum atrial septal defect, normal RV function, normal right ventricular systolic pressure with no evidence of the shunt reversal. On a CT scan, she had normal pulmonary venous congestions. And so we could ask the question, how would we treat her in Canada? Of course, we might want to do some further imaging with TEE, but generally a patient like this would be suitable for percutaneous device closure or perhaps a minimally invasive approach to closing it surgically. Once again, in Malawi, cardiac surgery not available. The patients are added to that long waiting list to go abroad, and she was also referred to the visiting team. So thinking about cardiac interventions specifically in Malawi, there's a growing appreciation of the need for patients like this to undergo advanced cardiac interventions within the country, even though basic management, for example, anticoagulation, is often deficient. So in view of this, there has been a collaboration started between the Ministry of Health, represented by the government hospitals, one of the private hospitals, Blantyre Adventist Hospital, which is administered by a faith-based organization, together with a North American mission charity termed Hearts for Mission International, which is also part, I believe, of the Seventh-day Adventist Church, which runs the hospital. And then the medical school, Department of Medicine, largely represented by me in this project. If we look at the next slide, there was a cardiac camp held about a year and a half ago in Malawi. The government of Tanzania and some of the Tanzanian cardiologists came over from a center there that offers cardiac surgery and screened many Malawian patients, identified many who could move to Tanzania, but it was never followed through by the Ministry of Health within the country. People ended up disappointed. We move to the next slide. I'll just show that this organization, Hearts for Mission International, is North American, as I say, largely based out of California. The next slide shows one of the founders, Dr. Tiffany Priester, who was a cardiologist in Malawi for about 6 years, from about 2010 up to about 2016, and she still visits the country once or twice a year. And she worked together with other interventional cardiologists and surgeons back in the United States to form this organization. So the next slide. So they had spoken to the Malawian government about taking younger patients, those who would not have coronary artery disease, simply because it can't be fully investigated in Malawi, and a limited burden of other comorbidities, trying to target patients who could undergo intervention for chronic rheumatic heart disease, for simple congenital heart disease, and for atrioventricular block. So, of course, time is moving. I'll give an account just of the 3 camps that they've had, and then move on to the second part of the discussion. They held a camp last year in November, just really to test the concept. And if we move to the next slide, you can see that 7 patients underwent open heart surgery. This was the breakdown: valve replacements, 1 valve repair and an ASD repair. And a couple of pacemaker procedures were undertaken, 1 new implant and 1 pulse generator replacement. Patients then return monthly for INR testing in the hospital. This is one of the GPs who helps to run that clinic, at which I also participate. And then if we look at the next slide, you can see those 7 patients who underwent surgery 6 months after their operation. You might be impressed with their youth and vitality. And the next slide, if you advance 1, shows that they are very vital and energetic after the surgery. If you just go forward 1 slide, even they're able to jump. So that was the first camp. Of course, the team want to demonstrate that it's successful to the Ministry of Health so they can get more buy-in. The visiting team, of course, is not just the surgeons, it's all of the supportive staff and equipment, which was sent over last year. The equipment remains and then is used by successive teams as they visit. And then I've just put in a few slides that the Canadian audience will be well aware of. Surgeons and their teams, the 3 surgeons shown on, I think, 2 slides. If you advance 2 slides, Sean. There's 3 surgeons there who participated in the second camp in April of this year. The larger teams shown in the next slide: nurses, physician's assistants, surgical assistants, perfusionists, critical care staff, and of course there's logistic operations as well, which is shown in the next slide, together with the perfusion team. We can move forward. So then in the second camp in April of 2024, they expanded services to balloon mitral valvotomy and pacemaker implantation. So the breakdown of procedures in the second camp: a greater number of patients, 12, underwent open heart surgery. There were 3 balloon valvotomies, one of whom was that patient that I showed you at the beginning with the mitral stenosis, and then 8 new pacemaker implantations. The next slide, of course, showing that Inui balloon and the implanting team. And if you just advance 2 slides, procedures are carried out in the operating theatre. You can see, I quite like this picture. Of course, I'm standing at one end doing a transesophageal echo with a cardiac anaesthetist, but at the other end, the cardiac surgeon standing with his arms folded. And Dr. Arega has been an incredibly supportive and indeed leading member of the team. He's originally from Ethiopia, but now comes visits from Kenya with each of these trips. But you can see that as the interventional cardiologist is working, he's got nothing to do. On the next slide, you see that first patient to undergo mitral valvotomy in Malawi. And then the next slide shows the chief executive of the hospital. They're very pleased about these kind of interventions. The next slide just mentions briefly atrioventricular block. They're all for high-grade atrioventricular block indications. All patients received a dual-chamber device, and you see some of them on the next slide. Of course, these patients, many of them are older. On the next slide, one of the patients leaving the hospital, her mother's carrying things on her head as they do. And if you just advance, then these are the patients from the second camp who underwent heart surgery. And the next slide is of that lady who underwent the balloon mitral valvotomy, who's now climbing mountains. If you go forward one more slide. And then just briefly talking about the third camp, which took place last month, the distinctive features of this were that the Ministry of Health supported a temporary cardiac unit, which there isn't one of in the country, providing dedicated beds, funding for some physicians and those clinical officers to look after patients, and facilitated the transport of patients from around the country up to Queen's, which was essentially a bed and breakfast facility that then they used the private hospital for the procedures. There was widespread engagement from the other central hospitals around Malawi, and the organization that I'll shortly discuss, MTIMA, is how we pronounce it, provided support for echo training. On the third camp, you see the summary of the numbers in the third slide. Again, it's a majority of valve procedures and then 7 pacemakers. The next slide shows that unit that the Ministry of Health kindly provided. And on the following slide, it's filling up with patients from around the country who attended. If you go to the next slide, I'll just mention MTIMA, a word that means heart in Malawi. It's an organization that I'm affiliated with as a founding member. On the slide is shown Marcello Na, who is a sonographer. He's just been awarded the Canadian Cardiovascular Society CSE Sonographer of the Year Award, which I believe he'll receive the next meeting of the CSE in the spring. He's our CEO. And as you mentioned, Sean, Carlos Fernando is also a very important part of that organization as the Chief Operating Officer. If you go forward one slide, this is just to demonstrate, in addition to the trips where I brought Canadians before, Marcello, Karim Taha have also visited. We've spoken to secondary schools about cardiac disease. We've taught medical students and various health professionals about point-of-care ultrasound. If you move to the next slide, Marcello was able to visit just before the surgical camp and indeed scan many of the patients who were identified through his scans as being eligible for cardiac surgery. And he's shown here with 4 of those team members, clinical officers and physicians who MTIMA are supporting for echo training. On the next slide is shown that patient who had the very low diastolic blood pressure with the severe aortic regurgitation after he returned following cardiac surgery. Lots of happy faces. And then just a couple more slides. A unit like this attracts a lot of attention. It's the first time it's been done in Malawi. The little short man in the black standing talking to me is actually the vice president of Malawi. So he made a visit to the hospital when he heard about the cardiac surgery that was being undertaken, and he got shown around the unit. If you go to the next slide, we were able to introduce some of those patients who had had cardiac surgery and explain their procedures to him. There's an election coming up next year in Malawi, and following the vice president was a man who went around with brown envelopes passing some kwacha to those patients with heart disease, which was greatly appreciated by them. In summary, then on the next slide, 50 plus patients have now received some sort of what we would term in Malawi advanced cardiac interventions. Of course, it's nothing like what happens in Toronto in terms of scale and complexity, but 32 have had open heart surgeries. There's been a few mitral balloon valvotomies and a number of pacemakers performed over the last 13 months. Finally, on this section, if we go to the next slide, you can see many of the patients from the first 3 camps, the surgical patients. So that's about 25 of them, I think, all looking young and healthy. I think we can move quickly through the next set of slides. It just summarizes the procedures again over the 3 camps. If the next slide just shows some existing challenges, we might want to talk about some in the discussion period. Why do we bother to do this? Cardiac surgery, it's a fairly complex treatment when there are basic health needs in the country. There's good arguments for pushing ahead with that. And then concerns about sustainability, the ongoing care of patients, particularly anticoagulation, and how those patients will be looked after if they're coming from remote areas of the country. If you just move to the next slide, things are a bit better in color, and the next slide shows these same numbers in color. And compared to camps number 1 and 2, the big difference with the 3rd camp is that there's a lot of blue there, and blue were patients in whom I was involved, but in whom I did not do the cardiac workup in terms of the echo. And if you just click on, you'll see one of the Malawians who wants to be a cardiologist who was involved in screening 6 or 7 of those patients for the 3rd camp. And of course, this is something which will only be sustainable in the future if Malawians take it on themselves. Also on the next slide in different colors that don't project particularly well, it just shows the broadening out of the regions of the country where people came from for their interventions. Next slide, where are we now? The final group of patients from last month's surgery will go home tomorrow. So I think we're going forward. Now, we've been talking for about 32 or 33 minutes. I'd just like quickly to move to the second shorter portion that I'd like to raise with you, and that's to do with the management of congestive heart failure. Here's a young lady who presented with shortness of breath, edema and palpitations 3 months after delivery, and you see she has physical exam signs of heart failure. The next slide shows her ECG. She's just about meeting LVH criteria by voltage with some repolarization abnormality and sinus tachycardia. Chest X-ray shows globular cardiomegaly with increased pulmonary vascularity. And if we move on to the echocardiogram, you can see she's got a very dilated left ventricle. And with that, on the next slide, functional or secondary mitral regurgitation. Next slide. On the apical 4-chamber view, you can appreciate that not just the left ventricle, but all 4 chambers of the heart are dilated. And then the next slide, as we zoom in on the apex, I think we might need to advance 2 slides to see not one of our friends, but a thrombus hiding there at the apex. Just the next slide. So there's a mobile echo density, which of course these ladies are predisposed to. So we made the diagnosis of postpartum dilated cardiomyopathy, much more common in Africa than in other parts of the world. So the next slide, we can ask again the question, how would we treat her in Canada? And of course, these would be the key elements: medical therapy, anticoagulation, contraception while her ventricle is recovering, as we hope it will, perhaps some advice about breastfeeding, controversial, the use of bromocriptine, and we'd follow well-published guidelines on how to manage the condition. And next slide, from the first edition, of course, we all are quite aware of this complex diagram, how we should investigate. And if we go to the next slide, we'll see that dilated cardiomyopathy comes out there with pregnancy in the third box in. So just a couple of minutes on guideline-directed medical therapy in heart failure patients in Malawi. Urban outpatients, rural secondary care level outpatients, and then something on urban inpatients. Just moving forward, this is the current version of the guidelines, of course. We have our 4 pillars: ARNI, beta blockers, mineral corticoid receptor antagonists, and an SGLT2 inhibitor with further add-on therapies. In Africa, Kenya is really the only country which has produced guidelines for the comprehensive management of cardiovascular diseases. They're quite a forward-thinking country, and the second edition was released this year, and they also support those 4 pillars. If we go forward, then we can get a sense of what heart failure management in outpatients was like in my hospital around the time of COVID, just when I was arriving in Malawi, actually. Dr. Mabutwa published this paper. If you go to the next slide, you can see him on the left side, and he's actually using an echo machine which came from London, Ontario. It was donated by a private cardiologist, and these 2 sonographers, CSE members, are donating that on the right side. So then he looked at about 80 patients who attended the best hospital in the country in the government side over about a 14-month period. He took some demographic clinical data and looked at sort of entry-level cardiac investigations, ECG and echo. The age was around 60, perhaps a bit younger than we would have in Canada. Females were about 60% of the population, and most were in class 1 or 2. They were ambulatory. About just over half had heart failure with reduced ejection fraction. And the main point I'd like to make actually from the next few slides is just the low uptake of guideline-directed medical therapy. You can see that about 3/4 of patients at the top of the screen were in ACE inhibitors, about half on beta blockers, and about 1/3 on aldosterone antagonists. So we're quite far behind other comparable countries. If we move on then, Partners in Health is a US-based organization that has traditionally focused on infectious diseases, but over the last decade or so, they've developed a non-communicable disease mission, really targeting what they would term as the poorest 1 billion people in the world who often don't have access to central hospitals, teaching hospitals, but even find it challenging to access their local district hospital. So one of their groups, led by clinical officers, presented data last year looking at their management of heart failure in a rural district in Malawi. The underlying causes, hypertension is the most common, followed by dilated cardiomyopathy, and then a mixed bag of valvular and congenital heart disease. As we say, the care is protocol-driven, delivered by this cadre of clinical officers, most similar to physician assistants. And it was a protocol that they had previously operated in Rwanda, which seemed to be effective. The difference between them and the government hospital, if we move to the next, this slide, is that the medications are in fact provided by Partners in Health, so they're able to access the medications, and they're including 3 of the pillars. I guess at that time, ACE inhibitors, beta blockers, and spironolactone. They do give secondary prevention for rheumatic heart disease, some additional medications that you see for hypertension, and then they mandate cardiology referrals. So, for example, I would see patients who they consider valvular or congenital, or if a patient needs pericardiocentesis, they would be referred to me at Queen's. the algorithm is shown here. They do point of care cardiac ultrasound and progress stepwise, making diagnoses of heart failure and valvular heart disease, right heart failure, and pericardial disease. We can move on. And then in terms of their outcomes, which is shown in the next slide, you can see that after about 1 year of follow-up, about 80% of patients are alive and still in the protocol, that is adhering to guideline-directed medical therapy. So they didn't publish the number that were actually hitting targets of drugs, but they did say that many patients remain in their program. So in this sense, they're doing much better than the government hospital. Of course, they've got that North American support. And then finally, I'd just like to mention the current situation in my department, the medicine department at Queen's. Some of our BSc clinical officers have just recently reviewed about 200 cases of heart failure who came in during the calendar year of 2023. Again, about 60% of patients are female, mean age about 60 years. And in our hospital, the median length of stay is about 8 days for acute heart failure admissions. Only about 10% were readmissions, and 90% they deemed to have had their first admission. But on probing, this was actually their first admission in 2023. And if you look, many of them, in fact, had a prior diagnosis made of heart failure. And so that would have been made on a previous hospital admission predating 2023. Males presented with more symptoms, but objective signs were similar in both groups. I don't know if you think that means that males delay coming to hospital, or that females are more resilient and don't complain. Again, the most common underlying diagnosis was hypertensive heart disease, and the most common precipitating factor was community-acquired pneumonia. Ischemic heart disease, I've seen 2 cases in the last week and a half of ST elevation MI, but that is not a common cause or precipitant in the population in Malawi. Comorbidities of anemia and impaired renal function are as you see. In terms of the diagnostic evaluation, you can see we are very, very limited in what is available in the government hospitals. A full blood count was only performed in 3/4 of the patient, and urea and creatinine in only 1/3, and electrolytes are difficult to obtain because of reagents. The results of an ECG or the tracing was only documented in 15% of patients. And because of this, we have adopted a policy of performing ECG on every medical admission. So now, in contrast to last year, we've got a bank of about 3,500 ECGs from May of this year, just people coming in for medical admissions. Echo was performed in about 40% of the patients, and those tests which are recommended in that second slide from the CCS, CK looking for muscle disease, the myocardial injury markers, pro-BNP, thyroid function, ferritin, not performed in any of the patient group. Since the focus is on medication, you can see that because of the high prevalence of hypertension, quite a number of patients were receiving a mix of cardiovascular medications, including ACE inhibitors, beta blockers, spironolactone thiazides, and calcium channel blockers. If we then go to the next slide, you can see that that number did increase significantly, but at hospital discharge or death, only 56% of patients were receiving ACE inhibitors, and only 1/3 receiving beta blockers or spironolactone. We get some clue in the next slide as to why that may be. There are very frequent stock out of medications in government hospitals in Malawi, and this limits care substantially, because patients then who are already in poverty situations have to go and buy at private pharmacies. However, if we go to the next slide, I think there's other underlying issues, even in the central teaching hospital. There's no uniform care pathway as we would have in Western countries, multidisciplinary, administered by nurses, physician assistants, physicians. So there's not really any guidance. People are left up to their own whim as to how to manage patients. There's no electronic medical records. It's a paper-based record. There's obviously insufficient access to very basic laboratory tests and cardiovascular diagnostics. We didn't until now have those dedicated cardiac beds, and decision-making was spread from very junior people across varying cadres of healthcare professionals. And as we've seen, that leads to a low utilization of evidence-based heart failure medications. And this very disturbing mortality just from last year of 13.6% for these acute admissions, which is substantially increased above other sub-Saharan African countries. So we've talked a little bit about rheumatic heart disease and how it presented. We've talked a little bit about heart failure management. I'd just like to spend maybe 2 minutes thinking and just opening up maybe. I know there may not be a lot of discussion given the time available, but I'm happy to share my email, and anyone who is interested can send more messages in the future. We'll go to the next slide. Christmas is coming, and so here's a Christmas wish list. It would be very nice to have visitors. I used to bring quite a number of visitors, as I said, perhaps 15 or 16 over those years that I visited from Canada. And in this sense, we're delighted to have a partnership between the Canadian Society of Echo and MTIMA, which should, all being well, see 6 Canadian CSE members come out to Malawi next year, cardiac sonographers, physicians in training, cardiologists in training, or indeed staff physicians. And this is something we're very excited about. Visitors can, as well as contributing to healthcare of individual patients, they can teach Malawian healthcare professionals. Of course, St. Mike's is very involved in training all sorts of cadres of medical professionals and allied healthcare workers. And so perhaps people may be interested in providing mentorship to some Malawians who are in training. People may be interested in donating their expertise, their time, or equipment. And if anyone is interested in that, I would suggest that MTIMA, as a registered Canadian charity, is a good organization to help to coordinate that, and we can provide more information. Of course, there are many opportunities for collaboration, perhaps in education projects or research. Certainly the Royal College provides education assistance and grants. If the CanMed rules are emphasised, I did consider applying for one of those myself whenever I was in London. The challenge was, of course, that it's difficult to find a partner in the other country, the target low and middle income country. So I would just wave a flag and say that as someone who's been in the Canadian system for 11 years or so, if there are people who have projects that they're interested in doing, perhaps in Malawi or as part of a wider group, then certainly we'd be happy to talk to you if you need that the global south partner. Other people may be interested purely from the point of view of humanitarian assistance or in helping to start a heart failure program. We are hoping, we've got a curriculum almost finished now for a Master's of Science in Cardiovascular Medicine, which we hope will start next September. And so we are hoping that we would interest people who may be prepared to supervise things remotely in that program. So I'm sorry, I've moved quite fast. I think I've spoken for about 45 minutes. There may not be too much time left, Sean, but I'm happy to take any questions. My acknowledgements are just there on the next slide, particularly to St. Mike's for the opportunity to present and wave a bit of a flag, and then to these other collaborators, and again to St. Mike's at the bottom. Thank you very much.
David, thank you very much for, first of all, for everything that you're doing and for sharing this journey that you and many others working with you have been on. I'll open up to questions. I'll stop sharing, although they're wonderful slides, for a second, just so that those who are online can have an opportunity to either use the chat function or you're amongst friends. Feel free to sort of raise your hand and or just shout out again, a very moving and impressive tour and journey, David. Maybe I'll start. I don't see anything in the chat function right now. You raised this a couple of times and finished towards the end with a potential wish list of ways that people can get engaged. But tell me, how does a country, how does the leadership of the country, where do they start? There's obviously and the different pathways that have happened, the different cohorts. There's been, some surgery that's occurred. Then you move to the sort of medical management, pointing out even earlier on that access to, for example, oral anticoagulation and other medical therapies, even as a stroke prevention or a stopgap measure, I'll say. Where is the sort of leadership from a government perspective on behalf of the people? What is their perspective on how there might be a path forward for sustainability of implementing, some of the programs, recognizing again that as daunting as some of these challenges and how impactful some of the interventions have been in a small number of individuals, where you have people, mainly below the poverty line and communicable diseases still, I guess, being the dominant sort of contributor to morbidity and mortality. Where does one start at the leadership level with trying to raise everybody's boats up?
Yes, thanks for that question, which of course is one that's most frequently asked. And the very last point that you made, Sean, is what one of those visiting American surgeons said to me about raising everyone's boats. And of course, I'm not a cardiac surgeon. I'm not an interventional cardiologist. I didn't come to Malawi to start a program for these types of interventions. But it is very much a flagship program. And of course, you can only support cardiac surgery and some of that advanced interventions if the basic cardiology components are put in place. For example, ECG, echocardiography, perhaps treadmill testing, other non-invasive imaging, CT and MRI. And so I think from the healthcare point of view, it's encouraging to have a program like this because it just raises the profile. And by giving people hope that they may be able to, if they're a patient, they can go through these procedures, then you're helping the patient. But it also gives some pride to the whole healthcare system in that they see that this can now be done, even in Malawi, albeit with the support of others. There is a Malawian training to be a cardiologist. In South Africa at the moment, there is an interventional cardiologist who is Malawian and an electrophysiologist, both of whom are working outside the country. And there's a cardiac surgical trainee as well. So I think it's more about raising all the boats at this stage. Coming to your other point then about trying to engage government and Ministry of Health leaders. Obviously, in a poorer country, resources are very limited. And they don't really want to know about problems that will cost them more money to fix. That's true, of course, in Canada and all Western countries.
I was going to say that's universal.
Absolutely. The rate of HIV, I think I mentioned it earlier, at 8% is the lowest it's been for 3 decades, probably in Malawi. Bill Gates, PEPFAR, USAID, and similar organizations are contributing vast sums of money in antiretroviral treatment, which is very effective. The current protocols are very effective. So the concept that there is no money available is false. It is available, but it's donor money. Right. The sad thing is that someone who has been treated for HIV for several years can come into hospital and die of hypokalemia because they couldn't afford the $2 to get their potassium level checked. So of course, these are difficult decisions that people need to make. But That would be my perspective, both on the healthcare provider and the political angle.
Appreciate that. I just wanted to mention it wasn't a question, but an offer from Chi Ming Chow in the chat function, because David, we've recorded with your permission these wonderful rounds that you've presented and shared your experiences with us, and we the potential to post this on our St. Michael's Hospital virtual echo rounds YouTube channel that Chi Ming is spearheading as a potential teaching resource and as a way to highlight so that you and your colleagues can access that. I just Chi Ming had mentioned that in the chat, so thank you again for everything that you're doing. Howard, I think Howard Leong-Poi has a comment or a question.
Yeah, just I know we're at the end, Sean. So thanks. So David, nice to hear from you and see pictures of you. You know, I visited London Health Sciences a number of years ago, and you were the Echo Lab director at that time. You know, just to highlight the MTIMA CSE initiative, you know, just announced earlier this year. So, you know, fantastic to support trainees and sonographers to visit Malawi and to work with you. So wish you all the success for that particular initiative.
Thank you very much, Howard, and also Chi Ming. And can I just say that we really do appreciate the assistance of the CSE. Igal and Sharon have been very, very supportive together with other leaders like Amr Jury in terms of engaging with MTIMA. And we hope that this is something that will prove helpful, not only in Malawi, but for those who are visiting, and that it can be expanded in future years as well.
Fantastic. Well, we're at the top of the hour. David, again, really an outstanding undertaking, and really impressed with what you shared. And the one other thing that I want to acknowledge is in the midst of all this, to be able to have some publications, or even you know, short of publications, some you know, some chart audits, some reviews, you know, in heart failure. That's certainly, as you well know, not even universal in Toronto or at our hospital. So it's very inspirational to see you know, that you're at least episodically being able to undertake some analyses, because if we don't measure, we can't manage, we can't get better, and that goes for all of us here, you know, in a so-called first world setting, with all kinds of resources. We do not do a very good job of that, and really kudos to you and your colleagues for undertaking that, amongst all the other things that you're already doing. So thank you so much. Great work. Lots of kudos coming through in the chat now as we wrap up. I'll remind everybody that when you log off, there is a quick link to the evaluation form. Please take 30 seconds. Doesn't take much longer to just fill that out and give David and everybody your anonymized, if you wish, feedback. Very important for our rounds, as always. And David, thank you for spending some of your evening time with us. And I know you've just provided your email address in the chat function, so folks can certainly reach out to you if they have some additional questions or comments. Thank you so much again for your time today, and thanks everybody for joining in.
Thanks, Sean, for the opportunity, and Carlos for assisting with the slide.
Yes, thanks, Carlos. Awesome.
Thank you.
All right, take care, everyone.
Thank you. Thank you.